Log on, tune in, find out. Another good idea from Cambridge.
Of this workshop. It's in fact a one-speaker session due to a last-minute dropout. And so the honored speaker of this session is Peter van der Ven, and he's going to tell us about an efficient alternative to the complete matched pairs design for assessing non-inferiority of a new diagnostic test.
I'd first like to thank the organizers for inviting me to give me the opportunity to present some of my more recent research on this conference. The topic is a bit different from the other talks we've seen so far, in the sense that it's not about comparing treatments or estimating dose response relationships, but it's about comparing the performance of two different diagnostic tests. The outline of the talk is as follows. I will first give some motivating examples and present the design which we propose. I will comment on the data structure and the statistical model and present some different an algorithm to estimate the parameters which we need for the statistical tests, which I will discuss after that. I will then comment on the efficiency of the design and basically explain under what circumstances these designs are more efficient than a complete match pairs design. And I will end by giving some examples, conclusions and extensions, possible extensions of the method. So the basic setup is as follows. We have we have two tests, a standard test and a new test. And basically our main aim is to compare the positivity rates of this test. Both of these tests are assumed to be imperfect, but we do not consider verification because the examples we encountered, there were lots of cases in which verification was not possible for ethical reasons or because there simply was no golden standard available for diagnosis. We look at the non-inferiority hypothesis, where our delta is actually our parameter of interest, which is similar to a relative risk. Delta 0 is a pre-specified constant. And this setup allows us to look at non-inferiority, for instance, by setting delta not equal to 0.8, or also it allows for superiority. If we set delta 0 equal to 1, then it's just a standard McNamara hypothesis for superiority. And I will say something about both of these cases. So the pi n and pi s in this case are positivity rates, which typically, in the case of are most informative if you know the specificity of the test is like 100%. In that case, the relative positivity rate is equal to the relative sensitivity, and that's also an advantage for defining non-inferiority in terms of the relative risk, because if you just looked at the difference between positivity rates, then it would still be the prevalence which would influence this difference. There are two situations which we consider. The comparison of positivity rates in situations where there's no verification is possible. This is, for instance, the case in studies with chlamydia screening, where patients that are diagnosed as positive are treated immediately, or in tuberculosis screening, people get antibiotics as soon as they have a positive results on the test. So you will never know whether they will actually had the disease or not. So it's not possible to verify in those cases. And another example is in cases where there is information on the gold standard, but you have the samples stored in a biobank together with the results on the standard test. And there's some reasons for testing for non-inferiority and allowing delta not to be smaller than 1. The new test may be more patient-friendly, easier to perform, non-invasive. It can lead to a faster diagnosis, or it is anticipated to be cheaper after implementation. Whereas in the design phase we assume that the new test is more expensive, which is typically the case if it's not yet implemented. So this is the standard design for comparing the positivity rates. It's just a 2x2 table where a set of M patients gets diagnosed with both tests. They can be positive on both tests and negative on both tests, but there can also be discordant results between the tests. And typically these are the most informative in, for instance, in the McNamara setting. But this, in some cases you might have very low positivity rates, and this design may not be optimal because you, you get very few information in these, very small numbers in these cells, for instance. And the majority of cases will be in the minus cell, which do not provide information on the test statistic in the complete match pair case. Another problem may be that the new test is more expensive, so you can do multiple, you can use a standard test because it's already implemented lots of times, but the new test is more expensive and you want to limit the number of new tests. And there are also many cases in which there are already results on the standard test are available. For instance, sometimes there may be a biobank with samples, and we see this more and more in medical research, that samples are stored for later use, and they can, if they're suitable for diagnosis with the new test, then these biobanks get larger and larger, and you don't want to do the new test on all the samples. So you could select a sample, and you could of course select a random sample, but if prevalence is very low, then it might be better to select all the positives and add some negatives to it, or at least oversample the positives in this case. Another example is a screening. When a screening program is running, there's information obtained on the standard test, and you could of course also do the new test on all these patients, but you could also use the standard test result as a stratification tool, for instance, by all the standard test positives typically come back for a second meeting at the hospital, and then you can ask them if they're willing to participate for the new test, and you can only select a small sample of a small subset of the negative subjects for getting your information on the new test. So this leads us to a two-phase design, where we first have the data on the standard test, and then we use a stratified sampling approach to select the subjects or samples that are administered the new test. And then out of, we assume that y and m minus y are fixed, and that's because we specify the distribution, because that's part of our design. So the standard test outcomes are assumed to be binomial, and within the strata of standard test positive and standard test negative, also the number of subjects that score positive are also assumed to be binomial, with parameters alpha and beta respectively. So the joint probability of observing A is the number of was the number of patients that were positive on both tests. B were those that were negative on the standard test but positive on the new test. and y is the number of positives that you select for the second stage, and x is the total number of positives that you find. So if the we can basically write down this probability in terms of conditional probabilities. First, x is sampled and a conditional on x. Y is fixed, and then for y we given y and alpha we have a and b, and so for this stratified sampling we assume that we as part of the design we specify a preferred a desired fraction of positive samples that we want to have in our total sample of M. Then we're going to I'm going to show some test statistics, of which some of them require all of them require the unrestricted maximum likelihood estimators, and some of them require the constrained maximum likelihood estimators. The unrestricted maximum likelihood estimators are easy. They're just standard maximum likelihood estimators for the binomial distribution. But in the estimators under the null constraint are more difficult to derive. Because the null constraint is of this form that's just found by writing pi n as a function of alpha, beta, and pi s, and then solving this function for pi s. And of course you could choose to we are choosing to eliminate pi s in the estimation because that will give us a rectangular region within which we can estimate alpha and beta. And if you eliminate alpha or beta, then we get a slightly more complex region. And in this way we can use a bisection algorithm to estimate alpha and beta. Well, I didn't write down the concentrated likelihood function in this slides, but it's a quadratic function in beta when you fix alpha, and if you fix beta, then it's a cubic function in alpha. So if we fix alpha, then it's easy to determine to maximize with respect to beta, and that's basically what we do in the bisection algorithm. We just start by this is the feasible region at a start, and we start in the middle of the interval for alpha, compute the maximum likelihood estimator for beta, then depending on the sign of the derivative, either restrict the interval to the upper part or the lower part, so we halve the interval there, and we do a similar thing at the second stage, third stage, and this this seemed to give it seemed to be a very fast algorithm to find the maximum likelihood estimators under the null constraint. We have compared three different tests to test for non-inferiority. The standard likelihood ratio test, but a signed version because we do one-sided testing. The nice thing of the likelihood ratio test is that it does not depend on the sampling procedure, because it's it uses the difference of the log likelihoods, and the sampling distribution then cancels out. That one requires the calculation of the maximum likelihood estimators under the null constraint. The scored statistic depends on the expectation of y, so the expectation of the number of positives on the test that you sample. So that needs to be taken into account, and that also requires the maximum likelihood estimators under the null constraint. We have also included a world type statistic, although world type statistics are usually not recommended for this type of data. but we just use it as a comparison, and well, it only uses the unrestricted maximum likelihood estimators, which we have in closed form. So that's why we included it in our analysis. So we looked at several cases in which we compared the empirical error rejection rates of the test. This is for a sample of, we start with 1,000 samples on the standard test, and we select 250 on the for the new test. The selection here is that we slightly oversample the smallest outcome category. For instance, if the real positivity rate is 1%, then we aim to sample 10%, 10% positives. In the middle, we just sample if the positivity rate is 50%, we aim to sample 50%, and if the positivity rate is 99%, then we aim to sample also like 90% positive. And in this case, especially this is for the for smaller within pair correlation, and this is for very high within pair correlation. The upper ones are for non-inferiority testing, and this is for superiority testing. And we see that the Wald statistic clearly has some problems, because it seems to its rejection rate seems to depend on the value of pi s quite strongly. There seems to be a positive relationship in almost all of these plots, which is worse in the with high correlation and superiority testing. And also in these cases, the likelihood ratio test seems to be a bit problematic for the higher positivity rates. And you would expect that the rejection rates go to zero here, because because the positivity rate is already quite high, and you do not expect to find a higher positivity rate on the new test. The score tests seem to do quite well, except for the very low positivity rates. There it seems to be a bit too liberal. We also looked at a smaller sample, and there we found some more problems with a Wald statistic, and also with the likelihood ratio statistic. In fact, only the score test was able to control the rejection rate below the around and below the 5% level in all cases, except for the small positivity rates. So this is basically a summary of what I just told, and we didn't look at even smaller samples, because I don't think that would be a good idea to use these asymptotic tests in those cases. We considered two settings for comparing the efficiency of this design to other designs. In the first case, to a complete matched pair design, but also to the design that we proposed, but where we use random sampling instead of optimal non-proportional sampling. We did this in a simulation study. We assumed a very large data set, but that was just to be able to oversample for all values of the positivity rate. I will first present the results for the superiority testing. In the power calculation, we assume that this is the relative correlation is the same within the under the null and the alternative hypothesis, because you cannot if we just fix delta under the alternative hypothesis, then we do not fix alpha and beta completely. So we have to put another restriction on the parameters, and we thought this was a relatively non-stringent assumption. So for the whole range of pi s, we determined the optimal fraction of positives that you should sample, and we used the bisection algorithm again to find the minimal sample size that was required for achieving 80% power. This is the reduction in sample size compared to a complete matched pair design. You see that especially near the in the lower range and in the upper range, there's a considerable reduction that can be achieved. On the other side, the other plot shows the optimal fraction of positives that you should sample. And you see here that for the lower pi s you oversample the positives, and for the larger pi s you undersample the positives and oversample the negatives. I will later give some theory for why that's indeed the case. You also see that here in the center we have well, proportional sampling is optimal, but still we find a large reduction in sample size, and that's possibly due to in our test statistic we use all n samples, the whole set of samples to estimate the positivity rate of the standard test instead of just the complete matched pair cases. So we also compared the power with the case in which we used simple random sampling of m units out of the n, not taking into account the outcome on the standard test. So this is the straight line is the power under the optimal non-proportional sampling, which we fixed at well, a value slightly higher than 80%. The lower case is the complete matched pair design with m samples, so m paired observations, and you see that random sampling is somewhere in between, and so in the middle it doesn't really matter how you sample the m units. You could use random sampling, it will give you almost the same power, but near the lower ends and upper ends, oversampling of the smaller outcome category on the standard test is preferred, because it still gives you an extra increase in power over the random sampling. Now let's look at the second example, which is a non-inferiority example, and again we set n equal to this large number. We use the same correlation, and we assume that under the alternative hypothesis the positivity rates were equal. Then we see a different picture. You can get a large reduction in the lower range, but this reduction well, is gone when you come into the higher in the range of the higher positivity rates, and you basically oversample the positives for all values of pi s. So it's a different. This leads to a different conclusion. Also here we examined to which extent there was an increase in power over a simple random sampling, and that there was a considerable increase, especially for positivity rates between 40%. So we found different sampling strategies to be optimal under the two types of testing, depending on whether you use you do non-inferiority testing or superiority testing. And why is that the case? So I plotted here the alpha and beta, which are the conditional probabilities of scoring positive on the new test, for the different values of the positivity rate, and you see that for the smaller positivity rates, I think the most straightforward to see why oversampling is beneficial in some cases, to look at the information that you get per sampling unit, and you see that, well, you do not get much information of the standard test negatives in this case, because they will, well, their pi-s is close to 0, but there's more information to be gained by the positive samples. And that's for the smaller, this is for the superiority testing. And well, in the for the larger values of the positivity rates, you see that the opposite is the case. You have you gain relatively less information by administering the new test to a sample that was positive, but you gain more information by administering it to a sample that was negative. So that's what causes the what explains the results on the oversampling we found. You oversample the smaller outcome category in this case, but in the in the superiority setting, then it's clear that in for the lower positivity rates it's almost the same, except for here you have even more even less information per unit in the on the standard test positives, so you oversample them more, and in this case the information is equal for both it's almost equal in both strata, so there's not really a need to oversample one of the two categories. So we've proposed this test and looked at this at this empirical rejection rates, and checked in what cases it would be beneficial to use oversampling and when you could use random sampling. I would now like to end with some some possible examples. This is a study done in almost 12 years ago, where the aim of the study was to compare the positivity rates of two screening tests for detecting chlamydia in an asymptomatic population. So the prevalence was really low. From this study, the estimated prevalence was like 3%. We spoke to some of the biologists involved, and they convinced us that these newer tests have very high specificity of almost 100%. So everyone who is non-diseased will get a negative result, and all the positives you find are likely to be true positives. So that then, it makes sense to compare the positivity rates of the two tests. We checked how much samples we would need in order to achieve 80% power, assuming this non-inferiority margin, this positivity rate, and a relative within pair correlation, which we also based on the previous study. And we found that almost 6,000 samples were needed. In the future there's likely to become a biobank available where they store urine samples on which you can perform the new test. So then you can basically select positives, use stratified sampling to select your positives and your negative samples. And if we aim for like 14% positives and the rest negatives, then you only need 3,000, and use the score test that we proposed, then you only need 3,000 samples to achieve 80% power, which is a considerable reduction of 48%. So if your new test is really expensive, then this can well, lead to some serious reduction in cost. Another example is in HPV assays for not for detecting HPV itself, but these HC2 tests can also be used to detect an underlying lesion. And in that case, well, we can compare the specificity of the tests. Specificity is likely to be around 93%, and if you want to show that a new test is superior, then a standard McNamara test requires well, almost 150 HPV women which do not have a lesion. And this, well, we didn't use the sample size formula for a McNamara hypothesis, McNamara test, but we use the empirical power to determine this number, because for this we found that in this range that was the approximation formula was not really a good approximation. It tended to really overestimate the number of samples needed, so then the comparison would not be really fair. Well, if you use stratified random sampling instead, so this is just simple. Let's see. Yeah, if we use the same number of women but use stratified random sampling and oversample the women that were that were positive on the test, then there's a considerable increase in power. Or we could choose to keep the power fixed at 80% and reduce the number of samples that need to be tested with the new test. So also in this case there's a reduction of 25% in the number of new tests that you need. So to conclude, well, we've derived 3 different tests for testing for non-inferiority using a design which uses stratified random sampling based on the outcome on a standard test. We used a definition of non-inferiority in terms of the relative risk. While the score test performed best in small samples, but this is also in line with results reported in this study. They also looked at non-inferiority, but they only looked at values of positivity rates above 50%. The only problem with the score test we found was for very low positivity rates, where it was slightly liberal, but overall it performed very well. And well, there are many cases in which non-proportional sampling can lead to a substantial reduction in the number of new tests. For non-inferiority tests, that's for small positivity rates, and for superiority, it's on both sides, small and large positivity rates. In these examples, we only use the dichotomous outcome of the test to select the samples that will receive the new test. But you could also, in most cases, there's this dichotomous outcome is determined on the basis of a continuous outcome that that provides more information. So you could then think of defining more strata, and we think that oversampling of samples that are close to the cutoff value might give you more information, and might even lead to a further reduction in the sample size you need. But this requires new tests to be developed, because you have to take into account the sampling procedure that you use, and then you could try and find the optimal strata definitions and the optimal stratification rates for each of the strata. Also, these are the tests proposed are all asymptotic tests, and they typically do not perform well for samples that are smaller than than 40%. So in those cases, you might, well, it would be nice to have some exact tests which could be used when testing for non-inferiority. So.
Okay, other questions or comments for Peter?
If the new test is more expensive than the old test, why would you do a non-inferiority test? I thought non-inferiority is something you would do if the new test is cheaper, so we want to introduce it if it's not inferior.
Yeah, there are cases in which the new test is more expensive when it's not yet implemented, but after implementation, then it's, well, there's more production and it can become cheaper. And also there can be other advantages if patients do not have to wait a week to get the result, but can hear the result one day later. If it's a non-invasive procedure instead of an invasive procedure. So these are the sort of advantages which might lead you to testing for non-inferiority instead of superiority. Yeah.
In your work, you've used examples where specificity was high. So what about circumstances when specificity is low, like 50%? And you're thinking about a test which is going to perform both in terms of sensitivity and specificity. Have you got examples where you've done that?
No, I didn't look at those examples yet, no.
But most diagnostic tests have relatively low specificity. I mean, some do have nice ones, but most have low specificity.
Yeah, and in that case, you really need to know the golden standard, I guess, in that if you want to compare the tests. And well, then you need then this test will not help you unless you have the golden standard in advance for all patients, which is typically not the case. But yeah.
So you looked at the relative risks of the positivities. But I suppose what you're trying to do with a high specificity is just trying to reduce the number of false positives. I wonder why you didn't look at the absolute risk instead, or the difference.
Sorry, can you?
Yeah, you were looking at the relative risks of the positivities. But my understanding, what you're trying to do is reduce the number of false positives in the test. So that would be your. So you to worry about looking at absolute differences rather than relative differences. That makes sense.
Yeah, well, I think that's just a choice that we made, and it's well, you can use either, but we found the relative risk more natural because it's well, it does not depend on the prevalence, which absolute differences will likely do. Yeah. But of course, you could derive a similar test, I think, for testing for absolute differences, and I guess you would get sort of similar results there. Yeah.
I suppose if it had been a superiority test instead of non-inferiority, the framework would be almost the same. You could use similar ideas.
In the
If you were testing superiority instead of non-inferiority, it would.
Yeah, we also looked at superiority, but a special case where the null, well, the relative risk under the null is equal to 1. You could set it even higher, and I think then you might want to oversample the negatives on the test. Yeah. Well, yeah, we didn't do the computations, but these results seem to lead in that direction. Yeah.
Other questions? If not, then let's thank Peter again.